Hello, and welcome to the Nursing Economics podcast series. This series provides extended content relating to articles published in the journal, such as interviews and roundtable discussions. Before we get started, we have a special offer for our listeners. You can save 50% off 1- and 2-year subscriptions to Nursing Economics. Simply visit nursingeconomics.net, click subscribe, and enter promo code NECSAVE50 to take advantage of this special discount. Overwhelmed by the people side of COVID-19 fallout? Worried about staff leaving and difficulty in recruiting candidates as the next nursing shortage looms? How can mission-critical outcomes be achieved with the ongoing stress related to COVID-19 as well as other crises on the horizon? This 2-part podcast series addresses the compelling and urgent need for organizations to develop healthy workplaces with emphasis on wellness among the workforce community. In part 1 of this 2-part episode, Doctors Therese Fitzpatrick and Nancy Valentine discuss the factors involved in framing the business case for transition to a wellness orientation for healthcare organizations. They address the concerns shared by leaders in nursing, medicine, top administration, and board members, and present the multifaceted factors associated with the occupational hazards associated with being a healthcare employee, and suggesting an array of specific strategies for program development. This episode provides extended content from the Claiming the Corner Office series in the September-October issue of Nursing Economics. We are pleased to present part 1 of this important discussion between Drs. Fitzpatrick and Valentine.
Hello, this is Therese Fitzpatrick. I am a member of the editorial board of the Journal of Nursing Economics. And today we're going to be talking about a really important topic for nursing leaders, researchers, and scholars, dealing with COVID-19 post-traumatic stress. Strategies for preserving the nursing workforce and supporting all frontline personnel. Because of the complexity of this topic, we're actually going to be running this as 2 separate podcasts. And today, our guest speaker, Dr. Nancy Valentine, will be addressing the factors involved in framing the business case for transition to a wellness orientation for healthcare organizations. 20 million nurses and midwives worldwide comprise 50% of the healthcare workforce. The COVID-19 pandemic has stressed this critical professional workforce to unprecedented limits. When the World Health Organization designated 2020 as the International Year of the Nurse and the Midwife well before the pandemic hit, the idea was to celebrate these essential healthcare professionals and bring to light the challenges often inherent in the profession. How prophetic that goal turned out to be. As the impact of COVID-19 on patients and healthcare systems began to manifest, nurses found themselves in situations never seen before, frequently working long hours with limited access, personal protective equipment, and evolving guidance on how to care for patients with the virus. The International Council of Nurses has confirmed that the number of nurse deaths now exceeds 2,200. And with high levels of infections in the nursing workforce continuing, overstretched staff are experiencing increasing psychological distress in the face of ever-increasing workloads, continued abuse, and protests by anti-vaccinators. And then there is the emotional toll with COVID-19 patients isolated and without access to visitors. Nurses have had to provide emotional support to patients and their families alike. In many cases, nurses have had the difficult task of helping families say goodbye to their loved ones by phone and video conference. Jennifer Taubert, worldwide chairman of Johnson & Johnson, has observed challenging conditions, new ways of working, and unrelenting global pandemic. All of this has created a perfect storm with the potential to seriously impact nurses' emotional and psychological well-being. In fact, in the current pandemic environment, Research has shown that nurses are impacted to a greater degree than their physician counterparts by stress, anxiety, and depression. This is due in part to the fact that nurses are the care team members who spend the most time with patients. As a result, they may disproportionately experience changes in operational procedures and protocols, shortages of PPE, heavy workloads, extended shifts, and the fear of exposure to the virus. International Council of Nurses CEO Howard Patton states this unique mass trauma is having an immediate and profound impact, but it is also highly likely to have a significant long-term impact as it contributes to a wave of post-traumatic stress disorder, depression, and anxiety, the scale of which we cannot yet determine. There can be no doubt that there will be a large COVID-19 effect on the size of the nursing workforce, which is already heading for a 10 million deficit. Even if only 10 to 15% of the current nursing population quits because of the COVID-19 effect, we could have a potential shortfall of 14 million nurses by 2030, which is the equivalent of half of the current nursing workforce. Such a shortfall would impact all healthcare services in the post-COVID-19 era to such an extent that I would argue the health of the nursing workforce could be the greatest determinant of the health of the world's population over the next decade. The burden now resides with our colleagues in leadership, education, research, and clinical practice to assess the impact of these devastating events on our workforce and to develop interventions to heal the psychological, emotional, and physical havoc COVID-19 has left in its wake. We have with us today an expert in all of these areas. Dr. Nancy Valentine has devoted her career both from a scholarly, leadership, and practice perspective on understanding and creating interventions directed to the nursing workforce for the sequelae of many of the issues that we discussed in this introduction, whether they be stress, personal and professional stressors of the job. So I'd like to introduce Dr. Valentine, and thank you so much for joining us both today and for the second portion of our podcast. Dr. Valentine is the president of the Valentine Group, LLC, which focuses on building quality systems and grooming results-oriented leaders using evidence to improve healthcare in practice and educational settings. With a diverse background in both healthcare delivery and education, Dr. Valentine's experience in many areas of healthcare, including top administrative roles in the federal government, military, city hospitals, academic health centers, community and university-based schools of nursing. She has held roles as Senior Vice President, Chief Nurse Executive at 3 academic health centers, Vice President for the Cigna Healthcare Insurance Company, and was appointed by the Secretary of the U.S. Department of Veterans Affairs to serve as National Chief Nursing Executive in Washington, where she successfully led the nursing workforce to be recognized leaders in caring for our very important veteran population. She has served as interim chair, School of Nursing at Northern Illinois University in DeKalb, Illinois, Associate Dean for Practice, Policy, and Partnerships at the University of Illinois Chicago College of Nursing, and recently worked with senior leaders at DePaul University in Chicago to develop strategic options and operational improvements for their School of Nursing. A fellow in the American Academy of Nursing, a fellow in the National Academy of Practice. She was also the first nurse elected to join both the Connecticut Academy of Science and Engineering as a fellow, as well as invited to serve on the Board of Trustees of Regis College in Weston, Massachusetts, where she was awarded an honorary doctorate. She's a founding board member and past president of the American Psychiatric Nurses Association, the American Psychiatric Nurses Association Foundation, and also served as president of the Friends of the National Institute of Nursing Research in Washington. Nancy has received numerous leadership awards and plans to keep working with nurses and health leaders on behalf of patients, families, and communities as a way of giving back for all the opportunities that she has had over the course of this illustrative career. Dr. Valentine, Nancy, I would really like to extend a heartfelt welcome to you today. I am anxious to get into this really important topic and know that based on your scholarship and experience, you'll be able to provide direction for our listeners. So if I could start, it's hard to recall a time prior to COVID. You have observed that nurses and nursing were already experiencing stress. Would you elaborate on your observations and share with us what trends were being reported even prior to this pandemic?
Well, very good. Thank you so much, Therese. That was a really great way to tee up this important conversation. I first, of course, want to thank you as a board member and certainly Dr. Don McKeevis, the editor of the Nursing Economics publication, because hosting this important podcast is really a step forward. And for me, it's an honor and privilege, of course, to have this opportunity to have a conversation with my leadership and management colleagues. And it is my hope that the time and effort and thought that we've all put into this podcast will be shared broadly with nurses in general and all healthcare leaders, and especially board members in particular, anyone who is interested in addressing well-being and mental health issues among nurses and all clinical staff. So let's begin with just saying, let's face it, stress, mental health, impairment as it has impacted the nursing workforce is not an easy topic to focus on. Whether nurses themselves, managers, or leaders, we often have a difficult time acknowledging such problems exist in the first place and prefer, of course, to talk about all the great heroics and innovations that have happened. Indeed, there are many positive outcomes as a result of the COVID-19 experience that has required charting a roadmap along the way. Inventing just-in-time solutions, new thought leadership, new innovations have yielded some extraordinary results. Great work like the Johnson & Johnson Nurses Innovate Quick Fire Challenge on mental health, done in partnership with the American Psychiatric Nurses Association. This year, J&J supported solutions for mental health practice that has championed nurse-driven innovation. The nurse innovators with the best ideas received up to $100,000 in grant funding and access to mentoring from experts across the Johnson & Johnson family of companies to help bring their ideas to life. But on the other side of celebrating, what we have come through with this experience is taking this time out, because having important conversations like we are having today and giving attention to the somewhat darker side of how this worldwide pandemic has affected individuals, families, and patients cared for, clinicians, own families, and even the institutions of healthcare overall is really crucial. How people have attempted to cope with fear, loneliness, and isolation really does deserve our attention. So, can we heal from this? Part of healing from any trauma involves talking about the pain and suffering involved and listening to the stories of those who have lived through this experience. This is a vital and healthy step if we are to move beyond tragedy and life-changing experiences. Such conversations give us a chance to take stock of where we are and where we need to go, both strategically and practically, in order to preserve our nursing staff and co-workers, as well as to improve outcomes, as these are closely tied together. From the time the first COVID alarm bells went off, I was deeply concerned about how this would impact our clinical staff, both on the short term as well as the long term. As Therese mentioned, having worked previously in the Department of Veterans Affairs, I learned firsthand about post-traumatic stress disorder, PTSD. So I anticipate we will all be dealing with this part of the aftermath of COVID for a long time to come. There are indeed lessons learned from PTSD treatment with military veterans that can be applied to our own clinical staff who have been through this traumatic experience. Bottom line, you may be able to be vaccinated against the virus, but there is no shot anyone has come up with for wiping away the memories, feelings, and sense of helplessness, and in some cases guilt, that so many people have experienced over the course of the pandemic. As you can tell, I am very passionate about the topic and dedicated to working with all stakeholders to address how we can learn and grow from this life-changing experience, where we all had to rise to so many challenges. The world now knows and recognizes that healthcare staff are among the first responders who assumed the brunt of the frontline drama, and were often the only defense between life and death is dignity, thus sharing the most private and heart-rendering moments imaginable with family and friends who had to be kept at a distance. The amount of stress on clinicians and healthcare systems worldwide is certainly unprecedented. No one could have fully prepared for this traumatic experience and all the associated social disruption, which of course is continuing. Who would have ever predicted or even prepared for how much would fall on the shoulders of the staff caring for the COVID patient population? You know, as part of thinking this through and thinking about the podcast and just living through the experience myself, I did get a chance to read This Great Influenza, the story of the deadliest plague in history, written by author John Barry in 2004. That alone is interesting because there are some striking similarities in how 100 years later, the pandemic of 1918 to 20 played out politically and how quickly it spread worldwide were very similar in many ways to what we have just gone through. Although there are not as many hospitals at that time and certainly not the technology available to support patients with severe respiratory illness, this account, this very long and very well-researched book, provided some context for what we have gone through with COVID. In the 1918 to 20 pandemic, people saw three waves of the virus. Their friends and neighbors, entire families died primarily at home. It was really pretty gruesome. Bodies stacked up in spare rooms or warehouses full of poor, given a backlog of burials, was pretty dramatic. The limitations of what doctors and nurses could do was painfully apparent. Doctors gave advice such as stay warm, keep your feet dry, drink fluids, keep bowels open, avoid crowds, enforce isolation, while they desperately tried to administer anything they could think of to fight the flu, none of which worked, by the way. Interestingly, during the 1918 pandemic, the skills of nurses were the most valued, as they could provide tangible comfort and support to both patients and families. Nursing them in their misery was coveted, and families of means fought over the few nurses available to be hired for private duty in the home. There were simply not enough nurses to go around, either in hospitals or in the community. The fact that in that pandemic, nearly 50 to 100 million people died, or 5% of the world's population, is simply staggering. So interesting that in the afterword of the book, the author makes a set of recommendations based on the lessons learned in 1918. If they had been read and followed by today's leaders, believe me, we would be in a very different place than we are presently. So it certainly begs the question, can we indeed learn from our experiences? Although 100 years later we are able to marshal more resources and apply state-of-the-art technology, nonetheless, the helplessness in saving lives still prevails in this scenario. Not having enough specially trained nurses to deal with this experience has been an ongoing issue as well. And of course, we've had new challenges to face, such as the impact of social media and fear of vaccines, among others. So for those who may not have been right in the midst of all of this, just how bad was it? For those who have not been on the forefront and maybe just listened to snippets on the news, to get inside the actual reality of the clinical experience of this current pandemic and feel what it was like to deliver nursing care to COVID patients and their families, I recommend that all healthcare leaders read one of the most poignant representations of what it was like to be on those front lines. The lived experience of being a nurse treating COVID patients was addressed in the February 25th, 2021 edition in the opinion section of the New York Times. This was written by journalist and nurse Therese Fitzpatrick, entitled, "COVID is probably going to end my career." Brown in this article focuses in on many contributing factors to what made this nearly impossible for nurses, but concludes that the healthcare system must address staffing, as it was a long-term problem and is at the heart of so many burdens that nurses assume, even before COVID. Clear and active representation of nurses in the workplace. In Brown's view, she credits unions rather than professional nursing organizations as taking the lead and seeking solutions to give nurses a greater voice. And it is an interesting perspective. But more importantly, to grasp the reality of this experience and to be transported into the ICU as a participant observer, embedded in the same article is a short film entitled Death Through a Nurse's Eyes, produced by Alexander Stockton and Lucy King. This film is a first-hand account of how nurses provided care and survived on the front line. In this film, nurses openly expressed that when they had time after a shift to process what they were indeed witnessing, they worked very hard to cover up their feelings and the trauma they experienced as a way to survive and even to protect their families when they would go home. This film is the single most poignant portrayal of how the pandemic has impacted nurses that I have seen throughout this whole ordeal. It is a very emotional account of the realities involved. So painful, it is really almost difficult to watch, but I invite you to do. I think you must watch it to see what really was going on. COVID, of course, brought leadership and staff in every setting to their knees. It is both terrifying and humbling to have an experience where one has so little control, especially in an industry where as leaders we depend on routine, regulations, controls, administrative and clinical experience in order to operate and get through each day. To have this wiped away so quickly was clearly destabilizing for everyone, no matter where they were in the world. And coupled with all of this, people were dying around the world. Healthcare providers were dying around the world, which was a chilling reality to have to live with as well. Who might be next? Therese gave some statistics in the beginning of this introduction, and I just want to add to that because in October 2020, ICN, the International Council of Nurses, a federation of more than 130 national nurses associations representing more than 27 million nurses worldwide, was reporting that 1,500 nurses were dead from COVID across 44 countries. But they had really had to revise that given the fact that so many deaths go unreported and the data reporting systems are so woefully lacking. It is actually estimated that the statistic is closer to 20,000 clinician deaths worldwide. Assuming that the healthcare workers infected with only 0.5%, which is considered a very conservative estimate. So the actual death and the threat of death has been with us for a long period of time. And so, in conclusion to that, it was indeed a war zone, fighting an invisible enemy, where nature is fighting a war with humans. Although we are in a spot where we are potentially putting the pandemic behind us, we are certainly not out of the woods yet. Dealing with the fallout of the pandemic, as it has affected nurses in the profession at large, must be actively addressed by every leader in healthcare. Everyone has been affected, not just those in the eye of the storm. It has rippled through every organization and every community. And leaders as well as staff need to recover. Everyone needs support. Therefore, with the perspective that we must take time to assess our organizations, let's take that broader view of we're definitely all in this together, as it is imperative to engage all stakeholders in the process of rebuilding. In the media sound bites, nurses and all clinical staff were certainly hailed as heroes, and accolades were very well deserved. But as we all know from combat situations, heroism does have its price. To be a hero is not just a one-way street. After the cheering is over, we are left with the real work, as we are talking about today, in dealing with the emotional fallout. So that's why I think it's important we're having this conversation. And as you pointed out, Therese, the very future of the workforce is in jeopardy. The people are leaving for all kinds of reasons. And CNOs are reporting nursing staff shortages, and in talking with nurses themselves, some report that their colleagues who could have practiced nursing for 10 more years, perhaps as they were taking the long road to retirement, maybe working part-time, whatever, have just opted to quit with statements as, I'm done. So we're picking up the pieces and we're trying to step back. We're really trying to recalibrate on every level. But perhaps we have to start with our own expectations, which I think is a real theme in this discussion. We have to really stop and think, what are we expecting of real clinicians and frontline staff? Can we have more awareness by consciously moving forward beyond expecting nurses, doctors, nursing assistants, and anyone in healthcare to have high levels of resilience simply as a combination of A, self-selection to go into healthcare in the first place, coupled with their professional and technical education and training, then expecting, them to be able to respond given the responsibilities involved in the roles they hold. These are crucial questions we need to ask ourselves. This is not giving people a free pass, as staff need to be held accountable to the highest levels. But it is entertaining the idea that we need to get underneath the behaviors that can be impediments and practice more prevention and early intervention. So whether we are consciously aware of it or not, we typically expect resilience to be literally in the DNA of care providers. And staff do have remarkable resilience, as defined by the ability to bounce back after a major event. They demonstrate this on an ongoing daily basis. But again, there are limits, and we have seen the reality involved in people reaching these limits across the nation. And perhaps we have to even think about expanding our definition of resilience. Just bouncing back may be not the best framework to have in mind. Not everyone starts in a good place before such a stressful event, such as this pandemic. So bouncing back is perhaps not the best mental model to hold, but rather envisioning an alternative view that with the proper support and an environment of the workplace, people can actually bounce forward and learn from the event and thereby gain more strength and reserve. And as we progress in this discussion today and our second podcast, we will focus on how this concept can be shaped. So we're at a turning point. We cannot really live with status quo, hoping that most people will just do okay, and the few who have overt problems, well, the general attitude has been, just go get some help, and if you can't get any help and you don't improve, perhaps you should just leave. Alternatively, we have to deal with this directly with a comprehensive set of strategies as part of a longer-term response to the consequences of the pandemic and other such things that can befall us, and build this onto ongoing operations. Certainly, if we have any hopes of preserving our current teams as well as to have future generations step forward. Now, I think it's wonderful that applications are up for schools of nursing and medical schools as a result of the pandemic. Young people have been inspired by what they have seen. But do we want the newbies, when they're ready to step into this landscape, to be stepping into what we have? Or do we want to stand back and build something so that when they do move forward, they will find a more welcoming and supportive space in which to grow and practice? One that builds on gratitude, health, wellness, and accentuating personal strength. With this as a starting point, there's more opportunity for professional engagement that then translates to giving this same care and attention to the patients we care for and for the community at large. I have to think of this as an investment that pays off. Nurses have been overwhelmed by the sadness, momentarily escaping to the break room to cry alone. This is not a solution. We need to have something involved where we redesign our work environments where self-recharging can be encouraged and addressed openly. People don't have to simply, like some of these cases, just sort of escape in order to recollect themselves. Now, Therese, you have laid out the problems very clearly in the introduction. The statistics really tell the story. And that's what we're going to really take a look at, because there are studies and information out there that really help to frame this new approach, this so-called business case. We've known a lot of this for a while. Nurses have had a lot of stress in their jobs, so stress among nurses is not new. These kinds of things need to be addressed. Before, some people addressed them, some people didn't. It really depended on the organization. But this has put a spotlight on what we need to change. So let's look at a few examples of these stresses. Some stress is related to the work itself. The systems, policies, and procedures that are part of the standard operating procedure of an institution can be very stressful. For example, work-related stress can be related to staffing patterns, which has been mentioned earlier, and that is usually the number one complaint among staff. Exists coworker conflict and bullying behavior, management conflict, workflow redundancy, which gobbles up a lot of time, copious documentation requirements, stress related to continuous support that nurses are expected to give to families and even to coworkers, in addition to their direct patient care activities. All these organizational factors and extra tasks add up to lots of formal and informal overtime. In addition, there are psychological pressures involved in the care process, such as neural distress issues regarding difficult choices clinicians sometimes have to make in providing care. These dilemmas are often focused on the individual provider feeling powerless to provide quality care, which then in turn generates conflict, which leads to more stress. For instance, during COVID, nurses reported greater moral stress and compassion fatigue in caring for patients which entail painful procedures, turning, intubation. Inflicting so much pain and seeing so many patients die nonetheless was torturous for the patients as well as for the clinicians. Many asked, was the pain and eventual death worth the care involved and pain endured by the patient? Another stress was as follows. The pandemic brought new challenges in how to deal with multiple technologies related to PPE shortages, the very scarce ventilator resources for patients, deep fear of contagion from job to family and community, and loss suffered with daily waves of death in the workplace. As one nurse commented, we are with these patients for long periods of time and get to know them and their families. And when we go off for a break and come back or take a day off, the next shift, they're gone. It is heartbreaking. Even people that were far away from the intensive care, they also had stress. There was an interesting example of a neonatal intensive care nurse who said that the nurses were so garbed in PPE, they had glasses and caps and masks and shields, that these tiny little babies did not see a human face for months. And they wondered, and we'd like to do some studies on, did that make any difference in these babies' ability to acclimate? There's also, coupled with all of these other stresses, I came upon the fact that there are a lot of folks who really just have been expressing their disgust and cynicism with the system. And some of it is just what they've experienced. They're fed up with the system of care fragmentation, lack of political will on the part of politicians, lack of responsiveness of leaders to fix known problems that have been known for years. Nurses on one website I reached out to ask for feedback about their experiences and how they have coped with it. They were very, very sick of everything they saw, and they were talking about how they were going to leave. Very disheartening, of course, to hear. When I wrote back and suggested strategies for bringing issues to the attention of key individuals, one nurse wrote back that she had written letters to politicians. She had really addressed it with her supervisory staff and attempted to play an active role, but in her mind, to no avail. So that's really sort of the stress on the job. There are other stressors that are more external, not anything that nurses are bringing upon themselves or the system is bringing upon themselves. It's sort of the environment in which they work. They work in very dynamic environments and are in close contact with the public, of course. So they really, as we are seeing more violence in our country and everywhere, airplanes, you name it. In studies that were done long before the pandemic, nurses are facing epidemic levels of violence in the workplace, and this has been documented. One of the studies by author Gordon Gillespie concludes that nurses are really in the middle of a lot of this, especially in emergency rooms, intensive care units. It can actually happen anywhere. That more education on how to prepare nurses for these like combat zones needs to be done within the educational setting. So if you think about it, we need to take a look at all of this violence and how it impacts the nurses. Because again, the studies that were done long before COVID, staff become burned out, and that is not uncommon. In a study of physicians and nurses, 40% of physicians in family medicine, emergency medicine, general internal medicine, 40% reported burnout syndrome. And those in clinical care units reported more than 50%. That's a lot of physicians. But in a meta-analysis of studies of nurses in ICUs, 25 to 33% report severe cases of burnout syndrome, and a whopping 86% report exhibiting one or more symptoms. Symptoms such as emotional exhaustion, lack of personal accomplishment, and the one I feel saddest about is depersonalization, where you just feel off your feelings as you're walking around giving care. And nurses also reported in such studies that if they work in a negative culture, that's even worse. It makes it worse. It is contagious. So the idea that building a healthy workplace is important is absolutely key, because that makes a big difference in how people deal with stress. Then the third area is personal stress. Not all stress is related to work. There's a lot of stress that people bring from home. In fact, I can actually use my own experience and scholarship when I was doing my dissertation. My focus of my study was entitled Stress, Alcohol, and Psychoactive Drug Use Among Nurses in Massachusetts, using a survey instrument and asking people about many factors, but there was a whole section on stress. This was a very large sample of nurses, 600, by the way, so it was very interesting to see these trends. Nurses really talked about most of their stress being from home. They also talked about how there was a high incidence and prevalence of alcohol and drug abuse in their families. Both of those reports I thought were quite interesting, because when you think about what people bring with them into the workplace, they bring a lot of things that we can't necessarily see. And this study was done, by the way, when I was in my career just starting out as a chief nurse. I was director of nursing, that's what the title was at that time, at Boston City Hospital. That was my first encounter up close and personal with nurses who had impairment problems. It was very dramatic. I'm telling you, if we had more time on this podcast, I could outline some of these things. I was young, I was naive, I was shocked by all of this, which was interesting because prior to taking this role, I had been the lead nurse on a Harvard-funded project that was a clinical trial of naltrexone. And in that study, we worked with hardcore addicts. So I learned a lot about alcohol and drug abuse. I was in a very incredibly rich academic setting to learn from many, many different scholars. But when it came to transitioning to a role in a nursing field, where I was now director of nursing and seeing the nurses who seemed to be very good at their nursing skills so impaired, it was shocking. Because of my background, I really wanted to help these people. I didn't know how to do it. I wasn't sure how to go about it. But over time, I did really learn that if we really approached this and tried to get people in treatment, that they actually could get better. But everything's stacked against you in this case. There are people in your organization that do not want to take that approach. The state boards of nursing are very woefully behind in some cases in terms of trying to help people get help rather than just go after their license. I have to say that there is no other professional group that is treated this harshly. And it is so damaging that when nurses are confronted, they often feel so much shame. They know that they're losing their jobs. They know that they most likely will lose their license, that many of them have started falling apart even more, and some have committed suicide. There is more documentation of that phenomena, and some very, very important work is being done by Dr. Judy Davidson, a research scientist at UC San Diego. And she has noted with her physician colleagues that the risk for nurses, whether they're male or female, is higher than the general population, and that it's something that has been unaddressed for years and is also the 10th leading cause of death in the United States, and it occurs 13 per 100,000 persons. But for nurses, it is much higher. And the use of opiates for the female nurses, benzodiazepines, they're the most common method of suicide, whereas there is more use of guns and other violent methods among the male nurses. So this is, again, all part of a continuum of information. And the question I'm asking all of you is how can we use this data to inform our actions? We need to work together because, again, another thing that I learned, this was a number of years ago, but my colleagues in nursing leadership were not that open to really thinking about how we could help these people. They were still going along with this idea that if they had nurses in their organization that had impairment, which they didn't believe they did, by the way, it was somehow a reflection on they as nurse leaders, which of course is a false conclusion. It has nothing to do with leadership. It has to do with there are a certain number of people that are going to have these problems, and we need to, again, own up to the fact that this is real and find solutions. I would say that hopefully COVID will be that tipping point that will change this perspective. As we can see from the data, many more people will exhibit problems and need assistance along the broad spectrum of mental health issues. So instead of even viewing impaired nurses in a separate category, I invite you to think about viewing them as less socially and professionally deviant than the fact that they are ill. Alternatively, we have the opportunity to reset our perceptions and view stress and mental health among staff along a continuum of experience. Some have mild and moderate reactions to stress, while others have more serious outcomes such as PTSD and associated impairment.
Nancy, thank you for that incredibly thoughtful and thorough perspective on the problem. And I think it's really important that you mentioned the notion that COVID has exacerbated many of the stressful issues that had been present in our environment prior to this situation. Let's turn our attention, if we might, how about everyone else? You mentioned that nurses are at higher risk for suicide in terms of anxiety and depression. How do we as nurses compare to the general population?
I think, again, we have to sort of assume a baseline and just know some basic facts, such as mental health is the leading cause of disability around the world. So we shouldn't be surprised that we have to deal with this too. So in looking at anxiety and depression, for instance, among the U.S. population at large, the National Institute of Mental Health reports that the incidence and prevalence is estimated that for anxiety, a little more than 19% of U.S. adults had any anxiety disorder in the past year. That's a number of people. Past year prevalence of any anxiety was higher for females, 23.4%, than for males, 14.3%. So an estimated 1/3 of U.S. adults experience any anxiety disorder at some time in their lives. Now, for depression, it's somewhat less. 19 million Americans, or 9.5% of the population, in any given one-year period will express the fact that they are depressed. But at some point in their lives, 10 to 25% of women, and really half that, interestingly enough, 5 to 12% of men will likely become clinically depressed. As you can see, these are large differences between the sexes. Adding this up, more than 30% of the U.S. population has experienced anxiety or depression in a given year. And you can see that women in both of these categories are higher, so we should not be surprised that nurses, being a female-dominated profession, would also be among these statistics. So 30% of any given workforce in a year is experiencing anxiety or depression, both of which are disabling, of course, to functioning at one's capacity. And these problems often can be observed in the workplace. So to summarize all these studies, we can see that it is helpful to view the need for interventions as a population health issue rather than simply as a person-specific, one-case-at-a-time issue. One can readily see from these statistics that people in healthcare are at a higher risk for mental health issues in general, and that was before the pandemic. I mean, just stop and think about it. If you're looking around at your unit, for instance, and 30% of the people are walking around with some level of anxiety and depression, we tend to not think of people in that kind of category. But as we will get into this discussion more deeply, being more sensitized and being able to pull some of that out to allow people to express it, to get help if they need it, to let the team have those discussions, will be very healthy. Again, I invite you to reframe. Shifting the focus and seeing mental health issues along a continuum of severity helps to get away from labeling the need for help in a stigmatizing fashion, which we do. We absolutely have a very hard time. We have to work consciously against not stigmatizing people. We are dealing, as I said, with an occupational hazard, not weak team members.
Thank you for that perspective. You've done a marvelous job here talking about the nursing environment as it relates to stress, mental health, and sort of the sequelae pre-pandemic. You did a really wonderful job highlighting now statistically from a large population perspective how these issues are impacting the population. But if we could turn our attention to these trends and how they may have been exacerbated by the pandemic. What are you observing in your scholarship and your practice, the impact on organizations, whether they be healthcare, acute care organizations, universities, across the entire spectrum.
Absolutely. And of course, it's no surprise. I mean, the world has become more attuned to this, and people are talking more about how they really feel. Let me just cite a couple of studies that I thought were particularly apropos to this question. In a 2020 study conducted by a group of public health experts, most of these people were deans of schools of public health, for instance. The title of this study was Prevalence of Depression Symptoms in U.S. Adults Before and During the COVID-19 Pandemic. Their findings suggest that prevalence of depression symptoms in the U.S. was more than threefold higher during COVID-19 compared with before the pandemic. And anyone that had lower social resources, lower socioeconomic, any kind of great stress, job loss, which, by the way, did happen among many nurses who were laid off in the midst of the pandemic if they were unable to practice in high-intensity settings, different services closed, et cetera. So they're in that group. They reported a greater burden of depression symptoms. The study concluded that post-19 plans should account for the probable increase in mental illness to come, particularly among all high-risk populations. So how does this really translate for clinical staff? There was a very interesting briefing that I sat in on, conducted a coping with COVID-19 study. This is very recent. They looked over physicians, nurses, and other clinicians. And it revealed that 49% of the sample population overall reported being burned out. Interestingly, mainly among the nurses. They were number one in burnout. The ambulatory care setting had the highest scores for burnout due to constant changing of workflows, channeling sick patients to hospital care, etc. This was followed by ICU and ER staff. Self-reported anxiety and depression was highest again for the nurses, 44%. Then support staff followed, then physicians and others. What I thought was also very distressing, but again, we have to look at the reality. Less than half the sample of all people of all different backgrounds felt valued, less than half. Clinical support and nurses felt the least support that anyone cared about them. Many reported planning on reducing clinical hours and or leave practice in next 2 years. This question was a wake-up call. First of all, the presenters made a very important point, that this question is considered valid and reliable as it has been tested in previous questionnaires. So they have done background research to know that this is really based on the validity of previous studies where people, if they do report they intend to leave, they actually do leave. They don't change their mind. So in this particular study, 1/3 of physicians said they were planning to leave their clinical practice, followed by 40% for the nurses, which again was the highest percentage. Nurse practitioners, interestingly enough, reported 32% wanted to reduce their hours to leave the practice. So these are predictive statistics. And even if it's close to that, that is a lot of people. So in summary, these specific professional and environmental factors and the incidence and prevalence of mental health issues really do contribute to the complex world of nursing. And these factors that are long-standing, again, we have to sort of finally stop and start to address them, because we can see why the welfare of staff often drops down on the top organizational goals, because healthcare organizations are working on so many other initiatives, other priorities, quality scores, getting ready for, various reviews, etc. But it's really critical that we stop now and do this. And there was another interesting thing I wanted to bring up. In terms of our focus, like putting our staff first, there was a book published in 2013 entitled Patients Come Second. These were two consultants, Paul Spiegelman and Britt Barrett. I'm sure many of you have read this book. The authors mentioned that this concept of even entitling the book Patients Come Second was considered revolutionary. They took a lot of flack from their colleagues because everybody wants to talk about patient engagement, putting the patients first. But their point was, unless you put the staff first, you're not going to get to putting the patients first. By their provocative title, Patients Come Second, they were really, again, trying to have some thought leadership by posing the idea that we must take a look at our engagement and improve our approach to our employees. And then they will indeed focus on taking care of people and they will exceed potentially the goals and objectives of the organization. Again, if you really boil it down, they wanted to have leadership rethink their rules and be less of a top-down command and control experience and replace this with behavior that is more coaching and engaging directly with staff, talking with them, helping them to have teams to solve problems. They felt that leaders would be more effective if they had this transformational leadership style, and that was a major theme of this book. There is no doubt lots of room to grow in terms of transformational leadership being adopted in our country. Otherwise, we would not have so many clinicians, especially the nurses, reporting that they felt no one cared for them. As one said, no one cared if I lived or died. These studies, just a few snapshots, again using data, help employers to be mindful of the impact of COVID on the workforce overall. We're at a different place. We really want to, move forward, and that's where we're at. I think that what we need to do is build a structure. We have to stop thinking that everybody's going to have resilience because they're nurses. We have to really start on this whole well-being and mental health scene and really get it on the radar screen so that in terms of being thought leaders, we will know how to begin to build a structure, and we really do need to find a place to start.
Thank you. I very much appreciate your observations and your citing some of these really critical pieces of literature. I think is really important for us. Let's focus on both your direct observations and scholarly work. How have these trends manifested in both nurses and nursing? Based on your scholarship, how do nurses often manifest professional stress?
As far as how they manifest it, it can be all over the map. But again, it all has to do with how we expect them to be resilient. And nurses hate to admit they need help. And this is not nurses, it's nurses, physicians, and anyone else with professional training that works in the field. There is an internalized sense of shame and stigma attached to asking for help. Nurses and physicians, again, among others, are held in high esteem and are seen as above such issues. They're used to being personally in charge, not being vulnerable. Toughing it out as a nurse or a physician is seen as a badge of courage to be able to rise to any occasion. And these are attitudes that are deeply held traditions, and they're not going to be easily swayed. Therefore, one of the things I would caution is that as we do move ahead and build programs, we can't use a build it, enable, come approach, meaning rolling out a new wellness approach could not work. We have to talk with our staff. We must have them directly involved in program design. They have to own it if it's going to work. And again, going back to what I learned in doing my work with nurses in Massachusetts, the nurses held out the longest for their serious illness. They have learned very well how to keep their problems to themselves. And the way they would do it is unlike other people like physicians or legal folks, they would be able to job change. They could change jobs if people were moving in on them. So they were very effective in knowing how to do that. And I think the other thing having to do with building healthy workplaces is that we're all, again, in this together. And by not having healthy teams right at the unit level, it's very common, believe me, extremely common, for problems to be ignored and people just sort of working around a troubled staff member. They may talk with others about how frustrated they are, but they don't necessarily take this any further. This is where the safety issues come in, because such an individual's distraction, lack of focus, inability for the team members to speak up, that often leads to errors, both small and large. And again, in terms of what makes this complex, is that it's our tradition to be selfless, work long hours, keep going that extra mile, and asking for little in return. And the education and overall orientation for clinicians is to focus on service to others, not to focus on self. This is rooted in very origins of early medicine and nursing. The state of selflessness may be laudable, but it certainly is not realistic in today's world of work complexity, as mentioned. Coupled with the requirement to step up so many unknown factors related to healthcare, such as in this case, a pandemic, we again have to recalibrate this orientation about how we educate and role model for students and how we support everyone in the workplace, not those who are just visibly stressed. There are many organizations that are dealing with programs. Professional nursing organizations are taking some leadership in this area, and we'll talk about that in our next discussion. And this is where, again, with the professional nursing organizations and healthcare organizations, delivery organizations can come together, and they can start to figure out how best to roll out programs. Couplings really will help us to move forward. In addition to showcasing, I think that there are opportunities for organizations and practice science research to foster measuring the interventions that work best. We have a long way to go in that area. It's just really at the beginning stage of this, Therese, but it is complicated.
Thank you for those observations. So no doubt the politicalization of both the disease and the vaccine has contributed to the moral distress experienced by our colleagues. Is this consistent with your observations as well?
Oh, absolutely. We cannot be surprised at the polarization of policies on how to mandate or not mandate vaccines for clinicians has been a dilemma for many organizations. Again, very complex. But I give a shout out for Houston Methodist. They were early to take that lead. That was a courageous step forward and mandate vaccines and deal with the fallout from staff who refused and quit. And they set an example for others. Many, many other organizations are now putting patients first. In this case, this is appropriate when we put patients first as to what is best for the community at large. Individuals, nurses, doctors, anyone, they have choices. But if they cannot tolerate such a policy, it's certainly their choice in not getting vaccinated, but they have to be expected to leave employment as a consequence. For staff working side by side with non-vaccinated folks is, of course, an additional threat and another example of moral distress among team members. I mean, just, again, picture nurses coming out of work and seeing people on the street who refuse to wear masks. While the same nurse may have witnessed several people die on that shift, it's extremely upsetting. Some of these examples of noncompliance actually border on the absurd. I'll just give one personal example. A family member of mine is friends with a couple in Texas and follows them on Facebook. They were very flagrant about not wearing a mask, not believing in social distancing, etc. The wife then unfortunately contracted COVID and was very seriously ill in an ICU. She luckily recovered and was able to be discharged. On their Facebook page, on the day after discharge, they posted photos of a celebration dinner at a crowded restaurant where she was sitting there using oxygen and neither was wearing a mask at the height of the endemic, celebrating her discharge. Now, I don't know who actually saw this, who had maybe treated her, but the clinicians who saved her life, who may have seen this post, had to feel a broad range of emotions. Risking their lives and health, all the while diligently caring for a person who refuses to comply, really is very difficult and drains valuable energy. But there's hope on the horizon. Just this week, the American Academy of Nursing and over 50 other healthcare professional organizations have come together and issued a joint statement that was published in the Washington Post, the New York Times, encouraging that everyone in healthcare get vaccinated. And when I saw this notification, I said, hopefully this will encourage the other 50% of our nation's people who are today unvaccinated. Hopefully that will help to get some of them to go forward and get vaccinated. So we have challenges at every turn. But the fact of the case points to the need for healthcare organizations to take a leadership role in the transition to healthy workplaces. I hope that with everything that we've discussed today, that it really helps you to frame that there is a business case. We don't need new statistics on the cost of turnover, the recruitment, the retention. We already know a lot about that. We're now seeing people leave in very large waves, and it's very difficult to recruit people in. A lot of the recruitment are for new graduates who are coming out of programs where they haven't had a lot of clinical experience because of COVID, another burden on orienting them and getting them up to speed once they are hired. But I want to say that this business case is what I hope leaders will be talking about. I'm sure that many of them are talking about this already, and there are some fantastic exemplars out there that can help shine a light on the pathway forward. Therese, I know we've spent a lot of time today. I hope this has been of help to our listeners. I want again to thank you and to all of our listeners for staying with it. And if anyone wants to reach out to me, discuss further, I certainly would welcome any discussion. But thank you so much for having me as your guest today.
Nancy, thank you so much for building the business case, laying out the complexity of this issue, and bringing in really important evidence into this conversation. So again, I would like to join Dr. Valentine in thanking all of our listeners. And I encourage you to look forward to the second portion of this podcast called Strategies for Developing a Wellness Program for Healthcare Organizations. Thank you, Nancy, and to all of our listeners. We will see you in the second phase of this important work.
The Nursing Economics podcast series is owned and produced by Genetti Publications, Incorporated. All rights reserved. No portion of this podcast may be used without written permission. Dr. Therese Fitzpatrick is a Senior Vice President at Kaufman Hall and a member of the Performance Improvement Practice specializing in workforce strategy. She is also an assistant professor in the School of Public Health at the University of Illinois, Chicago. Dr. Nancy Valentine is President, Valentine Health Group, LLC, which focuses on building quality systems and grooming results-oriented leaders using evidence to improve healthcare in practice and educational settings. For questions relating to this discussion, you may contact Dr. Valentine directly via email at valentinegrouphealth@comcast.net. For archived episodes of this podcast and to learn more about nursing economics, visit the journal's website at nursingeconomics.net. You can also subscribe to the Nursing Economics podcast on Apple Podcasts, Google Podcasts, Spotify, Stitcher, TuneIn Radio, our hosting site Spreaker, and everywhere podcasts are found. And remember, as a listener, you can save 50% off 1- and 2-year subscriptions to Nursing Economics. Simply visit nursingeconomics.net, click subscribe, and enter promo code NECSAVE50 to take advantage of this special discount.